We've covered insulin resistance, and now it's time to look at the other side of the equation: problems with insulin production. At first, when your body starts becoming resistant to normal amounts of insulin, the pancreatic beta cells respond by increasing insulin production. Hence the excessively tall stack of insulin mats placed next to the car so that Tutti Frutti up there can reach the driver's side door. Over time, however, the beta cells can no longer keep up, and there's a relative deficiency of insulin. This is a process known as beta cell burnout. So what's up? Why did the beta cells start lagging behind? Well, remember that genetics probably plays a big role. Maybe your mom gave you bad beta cells, you know? Thanks, Mom. Thanks a lot. What else? Let's see here. Oh, I know. How about excess glucose and free fatty acids building up inside the beta cells? This activates local cytokine release and disrupts beta cell function. An important signal for beta cell insulin release comes from the intestines, actually, in the form of incretins, such as GLP. Maybe incretin communication between the GI tract and the pancreas is interrupted for some reason, leading to inadequate GLP stimulation of the pancreas. Gulp. It's not really clear, so, just throwing that one out there. Check out the driver's name, Amy Lynn. It's meant to remind you of amylin, a polypeptide that's normally co-secreted with insulin from beta cells. It helps out with glycemic control by regulating things like gastric emptying and satiety. Now, in patients with chronic type 2 diabetes, amylin is not processed properly and gets stuck inside beta cell secretory granules, where they form amyloid aggregates. This is depicted by the pink amyloid gunk that's mucking up the wheel. Under the microscope, the amyloid starts to deposit around capillaries and between cells, and over time can take over most of the islets, which may also show fibrosis. There's also some evidence to suggest that amyloid is toxic to beta cells. But again, it's not really clear whether amyloid is causing the beta cells to burn out, or conversely, beta cells are already burned out and just start collecting amyloid. Like, as a fun hobby. 'Cause, they're retired and all. I kind of feel like I'm digressing. All right, so now we have a few factors possibly contributing to beta cell dysfunction. Crappy genes, glucose and lipids inside the beta cell just being annoying, ineffective GLP signaling from the GI tract, and amyloid accumulation, which may be just an effect of beta cell burnout and not a cause. It is just not her day. All right, one last point to make about pancreatic beta cells in type 2 diabetes. Turns out that you don't just have malfunctioning beta cells, but you also start losing beta cells, represented by this last beta wheel here, rolling out of the scene. Amyloid accumulation is also known to be a mediator of cell apoptosis. But on top of that, other factors, such as intracellular glucose and fatty acid toxicity, can cause oxidative and organelle damage and send even more beta cells into programmed cell death mode. Keep in mind, however, that even though type 2 diabetes is associated with a decrease in beta cell numbers, this is not the main driver of insulin deficiency in these patients. Don't forget about beta cell dysfunction. All right, let's get clinical. Typically, type 2 diabetes usually presents in older, obese patients. Compare this with your typical young, thin type 1 patient. Don't get too stuck on the age difference, however. With the increase in childhood obesity, type 2 diabetes is popping up in children more often than in the past. Patients with type 2 diabetes can present with polydipsia, polyuria, and polyphagia, just like in type 1 diabetes. However, type 2 diabetes is more likely to be diagnosed in asymptomatic patients. They're in your office for some routine blood work and, you notice their blood glucose is a little high. People with long-standing type 2 diabetes who have not received regular medical care may also have some systemic signs and symptoms of long-standing hyperglycemia, including blurry vision, paresthesias caused by peripheral neuropathy, and recurrent infections. A grandfather clock, like that big gingerbread clock in the stands, is our recurring symbol for chronic disease. And it's here to remind you of the many complications of chronic uncontrolled diabetes. These will all be covered in their very own sketch at the end of the chapter. So stay tuned. An acute, life-threatening complication of type 2 diabetes is hyperosmolar hyperglycemic state, or HHS for short. HHS is characterized by severe dehydration due to the ongoing osmotic diuresis driven by hyperglycemia. kind of like what we see in DKA. In contrast to DKA, however, patients with HHS do not have ketoacidosis. Because this condition is also called hyperosmotic hyperglycemic non-ketotic state, or HONK, we've added a car honking as it approaches the pit stop. We'll talk about HHS and DKA in much more detail in our next sketch at the finish line. All right, how about treatment? In type 2 diabetes, it's super important to encourage lifestyle modifications, including weight loss, physical activity, and dietary changes. Medications are often a part of therapy as well, but unlike type 1 diabetes, insulin is usually not the first-line treatment unless the type 2 diabetes is poorly controlled. Most patients with type 2 diabetes have endogenous insulin. It's just that their cells aren't using it correctly. So you can use special anti-diabetic medications that both decrease blood glucose levels, as well as increase the effectiveness of the body's own insulin. You can learn all about these medications in our Sketchy Farm course. Okay, time to look at labs. To diagnose diabetes mellitus, we need to look at blood glucose levels. And there are a couple of different ways we can do this. First, we can take a random blood glucose measurement, hence the random array of colors displayed on the flags. If a random glucose comes back greater than or equal to 200 milligrams per deciliter, along with clinical symptoms such as polyuria, polydipsia, and polyphagia, you can make the diagnosis of diabetes without having to repeat any testing. If the patient is asymptomatic, you'll need to repeat the test on a different date to confirm. Regardless, the big number to remember here is 200. Instead of a random measurement, how about we plan ahead a little? To obtain a fasting blood glucose, your patient must refrain from caloric intake for at least 8 hours. A fasting serum glucose greater than 126 milligrams per deciliter on 2 separate occasions is also diagnostic of diabetes. While it's typically used more frequently in the obstetric realm, an oral glucose tolerance test can also be used to diagnose diabetes. In an oral glucose tolerance test, 75 grams of glucose is administered orally and serum glucose is checked 2 hours later. If the level is greater than or equal to 200 milligrams per deciliter, the patient officially meets the criteria for diabetes. Now, in addition to just straight up measuring the glucose molecules floating around in the blood, we can also look at how much is glommed onto hemoglobin. You see, red blood cells are freely permeable to glucose, and when glucose sneaks inside, it likes to bind onto hemoglobin through a process called non-enzymatic glycation. Glycated hemoglobin, also called hemoglobin A1C, is represented by the glycating streamers hanging off that Formula One car with the hemoglobin wheels. Formula A1, that is. The level of hemoglobin A1C actually gives us a better picture of longer-term glucose control, because the hemoglobin stays glycated over the lifetime of a red blood cell, about 3 months. Think of hemoglobin A1C as an indicator of your patient's average glucose levels over the last 3 months or so. See the 6 and 5 incorporated into the design of the A1 car? A hemoglobin A1C concentration greater than or equal to 6.5% meets criteria for diabetes, though technically the test needs to be repeated to confirm the diagnosis. Although type 1 and 2 diabetes mellitus are commonly tested, don't forget about the other diseases that can lead to the same clinical signs and symptoms of hyperglycemia, such as Cushing syndrome, hemochromatosis, PCOS, and glucagonoma. Check out the respective Sketchy Path sketches for all the sacchariferous details. All right, time to wrap this thing up with 2 additional diseases of insulin resistance: metabolic syndrome and maturity onset diabetes of youth, or MODY for short. At Sketchy, we represent metabolic syndrome with a calorie-laden serving of metabolic brownies. They're being served to the king of Candy Valley himself as he watches the race below. Metabolic syndrome affects close to 25% of Americans. And as obesity rates continue to increase, that statistic isn't going down anytime soon. There are actually a couple of different definitions for metabolic syndrome, but essentially it involves a constellation of signs and symptoms including abdominal obesity, hyperglycemia, hypertension, and dyslipidemia. As in the case with type 2 diabetes, there can be a familial predisposition to developing metabolic syndrome. Thanks again, Mom.
You're welcome, Ricky. Oh, I left the casserole in the fridge for you.
Oh, sweet. As we discussed with type 2 diabetes, excess adipose tissue can cause direct inhibition of insulin signaling as well as inflammation that can worsen insulin resistance. And remember, it's the central stuff that's the worst. You know, the visceral and abdominal adipose tissue. This is highlighted by the King's tailor, trying to get his tape measure around all that abdominal girth. That brings us to diagnosis. It really depends on which guidelines you're using. But if we go with the most commonly used criteria, it requires the presence of 3 of 5 characteristic findings. Hence the 3 prongs on the fork he's wildly brandishing. What you're looking for is a fasting glucose greater than or equal to 100, blood pressure greater than or equal to 130/85, triglycerides greater than or equal to 150, HDL less than 40 in men or less than 50 in women, or a waist circumference greater than or equal to 40 inches in men and greater than or equal to 35 inches in women. So why is metabolic syndrome important? Couldn't a hypertensive patient just have low HDL and be a little on the chubby side? Well, sure. But metabolic syndrome increases your risk of developing other diseases. I'm not going to sugarcoat it. Patients with metabolic syndrome are about 2 times more likely to develop cardiovascular disease. Wow. Sorry there, buddy. Actually, you know what? Never really liked those candies anyway. Too chalky, you know? And they always say weird stuff like, say yes and crazy for you, or like, stalk me if you have time. Not into them. Also, we've made the Candy King pointing ominously at racer number 2 to emphasize that patients with metabolic syndrome are 3 to 5 times more likely to develop type 2 diabetes. Not surprisingly, management of metabolic syndrome involves lifestyle changes including diet, exercise, and weight loss. Pharmacotherapy may be needed to manage hyperlipidemia or hypertension, for example. And finally, mature onset diabetes of youth, or MODY, characterized by the development of non-insulin dependent diabetes at a young age, usually before the age of 25. Non-insulin dependent means we're dealing mostly with insulin resistance rather than an absolute deficiency, kind of like type 2 diabetes. So we have our young moody prince here, pointing down towards that type 2 diabetic racer. MODY is transmitted in an autosomal dominant fashion, hence the dominant domino symbols incorporated into the shutters. And in contrast to type 1 diabetes, patients lack autoantibodies. The autosomal dominant genetic mutations associated with MODY affect everything from beta cell development to glucose sensing to insulin secretion. Definitive diagnosis can be made by testing for these genetic mutations. And that's it. We've unwrapped everything you need to know about the pathogenesis of diabetes. Recall that type 1 is an autoimmune-mediated disorder characterized by beta cell destruction and an absolute deficiency in insulin. Expect an inflammatory infiltrate on histology, mostly T cell, by the way, as well as a decreased number of beta cells and islets of Langerhans. Genetics-wise, just remember 1, 2, 3, 4. Type 1 diabetes, a messed up HLA-2 gene, specifically the HLA-DR3 and DR4 haplotypes. Classically, patients with type 1 diabetes are thin. Think of it this way. Without insulin, you can't move glucose into cells to store as fat. Not only that, but you've got rampant gluconeogenesis that's stealing amino acids from muscle, as well as overactive hormone-sensitive lipase breaking down your fat stores. All that catabolism makes them hungry. Meanwhile, type 2 diabetes is characterized by insulin resistance. At first, insulin secretion increases to compensate, but in later stages, the beta cells get burned out, resulting in a relative insulin deficiency. By relative, I mean that there's usually some insulin left, just not enough for the body's demands. Family history plays a big role here.
You're welcome, Ricky.
And the biggest modifiable factor is obesity, especially that abdominal kind, messing with that insulin signaling. And finally, we reviewed the metabolic syndrome, which is associated with an increased risk for developing cardiovascular disease and type 2 diabetes. Then there's maturity onset diabetes of the young, a type of moody, non-insulin dependent diabetes that's inherited in an autosomal dominant fashion and usually occurs before the age of 25. All right, to sweeten the pot, we have a second video that goes into detail about the complications of type 1 and type 2 diabetes, focusing on DKA and HHS. So I'll see